when a person is diagnosed with an infectious disease, there are state laws that require a care provider to report that to a state health department. Many infectious diseases, this is the case. Some cancers, so some non-infectious diseases as well. I worked with HIV and tuberculosis. So HIV specifically, clearly in the early days of HIV in the 80s and 90s, when stigma was, still a problem, but when it was a real, problem where people were getting fired, getting evicted, housing was a huge issue. People were afraid to stand by people with HIV or, be in the same room with people with HIV. People got their houses burned down because they had HIV. Real severe, life-threatening stigma. We worked very carefully because this is data collection in the background where individual people don't have a choice about whether their data are collected, and they get collected by the state health department. They're then sent to the Centers for Disease Control and Prevention, de-identified, sent to this wider national data set. I worked on that system, and as a person who believes very strongly in privacy and has very, I've always been an extremely active in this idea that, people should have privacy. It seemed like a bit of a conundrum for me or a paradox for me to be really clear about people having reproductive and health privacy, and then being extremely supportive of good data coming in on HIV, something as controversial and stigmatizing as HIV. So it was for everyone who worked on this. And we ended up really working hard to get national HIV reporting. And this was controversial and very difficult in the 90s, primarily because people on whom the data were collected were afraid. Were afraid of the government having their name when they weren't sick, when there was nothing anyone could do for them. And they would be sitting in a database for what? Nothing good was going to come to them from it. Nothing, they were going to get absolutely nothing from it. Where was the justice in that was the question. Where was my benefit? Where's beneficence in this? Where's my autonomy? So we talk about all these terms around ethics and people saying, where's my choice? Where's my consent here? All of which, for me, it was like, wow, I really have to make peace with this for myself, because I'm a person who believes in all those things. Like, that would be me talking if I didn't believe so firmly and so deeply in the idea that data gets us what we need. And how HIV data got us what we needed then was it got us money from Congress, and for each state, it got each state the portion of the pie Congress gave us for prevention and control. If people were unwilling to be counted, if HIV was going to remain an ignored, a silent, a covered up, an undercover, an ignored disease, we would never get money to treat, to do prevention, to get life-saving medications, and people would be hurt by that. People with HIV would continue to be stigmatized. They would continue to be left from removed from their homes. They would continue to suffer from great injustice. So it was this time to really try for me to make peace with and cope with this tension between how we do what we know we have to do to get the benefits of the funding and the attention and of this devastating, life-altering disease that takes the most productive years of a person's life, and the trade-off. And the only thing that assured me that the trade-off was worth it was that it was me and people like me doing the surveillance work. Like, I'm the one who has your data. If anyone tries to use these data in a way that I'm not okay with, they're up in flames. We're okay. You're good, because I'll burn the house down with the data. We're not going to let that happen. So it was a long 10-year slog to get this to happen, but with really effective community engagement, with people who were in the community working hard to help people understand what the uses of the data were, how they were protected, with really working closely with legislatures across the country to help put laws in place that these data could not be subpoenaed or used for, reasons other than public health. It was, slowly, domino by domino, it happened, and it ended up being, what it took to get HIV services everywhere, where we had personnel in every single state, CDC funded personnel in every single state, at least one person, and many more in high morbidity states, to do HIV data collection, to work on HIV, distribution of funds, et cetera. And no other disease has had that. And it's because we had good data, accurate, valid data, and complete surveillance information. To make sure that those data were protected and all those things that I talked about in terms of the ethical issues, that privacy was protected, that people felt engaged and in control of what was happening, and by people, I mean people in the community, we had to do a lot of work in ethics. And we had the privilege of working with, all the amazing people who do this work. Larry Gostin, who is an amazing, prolific lawyer and ethicist, public health lawyer, who, worked with CDC to really think through what are the principles that we need to put forward, that all health departments, that legislatures need to think about in terms of keeping people safe. And by keeping people safe, I mean keeping their data safe. And we made some pretty amazing headway. And it was about the most satisfying decade of my life in terms of my professional work.